Yeah, so I think it's been clear for several years that MRD, the level at end of treatment, predicts what's going to happen 2, 3, 4, 5 years down the line. And since the ibrutinib era, it's been maybe not so important as patients have had very good prolonged remission without having deep remission. So you can have residual disease even at quite a high level without getting disease progression. But that comes with consequences, particularly cost and the risk of clonal evolution and developing resistance mutations. So we've seen over the last year or two development of fixed duration therapies, and that takes us back to a similar situation where we were with chemo-immunotherapy, in that people are having treatment for a certain amount of time, but the responses are incredibly good, very deep remissions, and so it's challenging to do a clinical trial where the progression-free survival is likely to be 5 years plus. We know from the data that we have that the rate of progression from end of treatment after, say, venetoclax ibrutinib-based therapies is similar to the chemo-immunotherapy era, so we can use the data that we had from those times to kind of work out exactly what the level of disease at end of treatment means for the likely progression-free survival. So we've been looking at a couple of issues that are still maybe to be resolved. Certain things that are very much settled. The clinical threshold is ideally to remain at 1 in 10 to the 4, so less than 1 CLL cell in 10,000 leukocytes. Even though we have plenty of technologies that can go much deeper than that, the difficulty for changing the threshold that you look at, it kind of loses all the historical data. So if you change the threshold, it means you don't have the same ability to interpret what an MRD negative or positive result means. And so we're trying to ensure that people stick in terms of clinical reporting to that 1 in 10 to the 4 threshold, while also appreciating that if you want to develop a curative strategy, you might want to go a lot lower. So you know if you're going to have a cure, you want less than 1 in a million. So there's challenges in how you actually talk about MRD responses in terms of the regulatory approval and how we relay that as a simple message. Positive versus negative around a 1 in 10 to the 4 threshold remains the same, but then below that, how do you report when the level of disease is 1 in 10 to the 5 or detectable at 1 in 5 times 10 to the minus 6, this sort of thing. So we've had a way that's probably applicable to a number of different diseases, a number of different hematological malignancies, of saying positive or negative according to the clinical threshold. That might be 1 in 10 to the 5 for myeloma, 1 in 10 to the 4 for CLL, ALL, maybe 1 in 10 to the 3 for AML. But then to report below that, maybe use MRD3, MRD4, MRD5, MRD6 to relay the fact that the depth of remission is better than the clinical threshold. And then you also have to consider whether it's detectable or undetectable. So you can have certain assays that will be where you'll know the result below the clinical threshold. So if you had 1 in 10 to the 5 by next generation sequencing, that would be negative at the clinical threshold, but positive at a lower level. So we were discussing how to report that. It's a philosophical thing, but it's probably quite important to make sure that people capture all of the information. And then there's another more practical issue about whether you measure in the peripheral blood or bone marrow. This is ideally peripheral blood monitoring would be the way to go, because you don't want to have patients going through sequential bone marrow assessments to determine when is the appropriate time to complete treatment. But still, the bone marrow is the most sensitive place to measure MRD. We're finding approximately 1 log difference between peripheral blood and bone marrow, so tenfold difference, tenfold higher in the bone marrow if you've had recent rituximab. If you use ibrutinib, that brings the cells out into the peripheral blood, so that can counteract it. So if you're on obinutuzumab, it's maybe half a log. And if you're on venetoclax alone, also there's a slight imbalance, about half a log difference. So what it means is that patients who become MRD negative in the peripheral blood at that 10 to the 4 threshold may well have a higher level, and we usually do have a higher level in the bone marrow. So the challenge for the trial design is to find a way to measure the kinetics in the peripheral blood and identify the best time point to say this is the time to capture the global MRD assessment? Or is it possible just to do it just with peripheral blood? So venetoclax plus ibrutinib, or those two reagents will have that slight difference between peripheral blood and bone marrow, but easily manageable. Obinutuzumab, other anti-CD20 agents are a lot more difficult. It probably takes up to a year to clear the antibody from the peripheral blood, or to get to a state where the peripheral blood is representative of the bone marrow. So those are the things we were discussing in the main session today.